Good morning, all of you. It is a great fortune and have a good teacher and a great academician, Dr. Srinivas samavedam, and he's had a MD in internal medicine and DNP medicine, FRCP, FNP critical care medicine, EDIC, FSA, and chief intensivist at Samavedam Hospital, President-elect ICCM, and Associate Editor of ICCM. I am very happy to introduce him, and he is a everybody knows him as a good teacher, not only teacher, as an academician. He will give a lot of, so many lectures given throughout India. I welcome to present his presentation. Applied cardiovascular physiology in a critically ill patient. That is most important, a basic topic for the basic knowledge of the cardiovascular physiology in a critically ill patient. I welcome you, sir.
Good morning. Thank you, sir, for the kind introduction, and thanks to the Reflect team for having me here. 20 minutes to talk about cardiovascular physiology is simply like 277 runs in 10 hours. I will try to get at least till 2:45. So one of the core principles of physiology, it is not only cardiovascular physiology, any physiology, you take cerebrovascular physiology, you take pulmonary physiology, renal physiology, it is a pressure-volume relationship that is a core fundamental principle of human physiology. If you look at the volume of the brain versus the pressure it distends, you try to regulate the volume in the brain to regulate the pressure. Same thing happens in the lung. If you distend the lung with a set amount of added volume, it generates various kinds of pressure. And when you translate pressure of a static lung at end expiration and increase it, it converts potential energy to kinetic energy, and therefore there is change of energy which cannot always be lost, so there is power. So that is the fundamental principle of pulmonary physiology. Same thing appears to be applicable in cardiovascular physiology. Your first response when your patient has a drop in pressure is to challenge him with volume, expecting that this change in volume will actually translate into an exponential increase in pressure. Now that concept is good as on paper when you look at the laws of physics and you say when you fill a contained sand with volume, it distends pressure on its walls and therefore the pressure should rise. But that is also dependent upon the elastance and the compliance of the system to which the pressure is being applied, be it the cerebrovascular architecture, be it the alveolar architecture or the cardiovascular architecture. So how well the set structure is able to absorb this volume and how well it is able to relax when this volume is released is the difference between compliance and elastance. So elastance is the opposite of compliance. So that is another fundamental principle of cardiovascular physiology. But like the brain, the intrathoracic compartment, the heart, exists in a closed space with a few recesses though, but it is essentially a contained space. So what is happening around the heart, in the thorax, in the pleural space, in the mediastinum, and essentially in the lung, in a critically ill patient who is on positive pressure ventilation, has an impact on what is happening in the other structure which is enclosed within between these two lungs which are under pressure. So that is the intrathoracic pressure and its influence on the way the heart behaves to changes in the volume status of the individual. All these relationships, whether it is the pressure-volume relationship, the relationship between compliance and elastance, and the change in intrathoracic pressure versus the output from the heart are non-linear. Unlike in a physical sample, if you do in a physics lab where there are no external pressures, it's an exponential curve. It's not an exponential curve in the human physiology, it's always a curvilinear form with a rise, a plateau, and a fall. So where we are actually looking at the patient in that part of the hemodynamic curve is what is important. So if you want to bring hemodynamic and cardiovascular physiology into a nutshell and see what we are trying to do, the major determinant will be the heart, That this whole, the pump, the pipe and the tank concept is an oversimplified way of understanding physiology, because everywhere we are looking at a closed system. As we shall see, there is an unknown system where the huge volume of fluid or a reasonable volume of fluid is stored, which is never coming into circulation unless you press it to enter into circulation. We'll come to it as we go. So either you take it as the tank, that is the venous capacitance vessels that actually come back into the right heart, and the left heart pumps it, produce a cardiac output which distends the elastic arteries, therefore produces a pressure called as the arterial pressure. You call it the mean arterial pressure, and then it comes back down into the right heart to distend a pressure on the right side called the central venous pressure. So this is the gist of what all the hemodynamic system is all about. It's impossible for me to describe every single aspect of this fantastic piece of creation. I will try to discuss a few core concepts which we use in our daily practice in intensive care. What we will try to discuss is the mean arterial pressure first, because if you look at all the guidelines, all the literature, the only one variable which nobody has any problem with in accepting as one of the targets for resuscitation is the mean arterial pressure. Because the mean arterial pressure is an integral component of an essential feature of how the organs get their blood supply to the heart, how the nutrition from the blood gets into the tissues, and how the tissues utilize it is dependent on a pressure called as the perfusion pressure. Now the mean arterial pressure is the one component of the calculation. If it is in the brain, it is the ICP, you trigger it. In the heart, it is the diastolic blood pressure, you remove it. In the mesenteric blood flow, the diastolic blood pressure in the mesenteric blood vessels and the intra-abdominal pressure. You subtract it from the mean arterial pressure, you get a cerebral perfusion pressure, you get a coronary perfusion pressure, you get an abdominal perfusion pressure, and you get a renal perfusion pressure. So after mean arterial pressure, it is the perfusion pressure which makes a difference into how well your organs are able to get the blood supply which your heart is trying to pump into them. So we'll talk a little bit about perfusion pressure. But the most interesting philosophy we all need to understand is the main systemic filling pressure. We all say that the heart is a pump, right? But if you look at the mechanical pump which is installed in your house to pump water from your sump or your tank or whatever, that pump can generate negative pressure. It can suck from peripheries. The heart does not generate negative pressure. The heart actually reacts to a volume that is coming into it at the end of diastole, and that stretch by invoking the Frank-Starling principle makes the muscle to relax and contract. Where is this volume coming from? That volume is the main systemic filling pressure, which keeps the heart circulating and triggering it to function. So the main systemic filling pressure, distending the Frank-Starling principle will be another concept we will look at. Most importantly, in a critically ill patient, your judgments currently, your decisions currently, whether my patient is actually fluid responsive or not responsive, will he respond to a bolus of fluid? If so, how much? Is all determinant upon how the heart is reacting to the interaction of the positive pressure changes that are happening in the lungs. If you go back to physiology, this is an application of the principle of pulsus paradoxus. You reverse it because the respiration, the positive pressure respiration is a reversal of your natural spontaneous breathing. You get the application of the heart-lung interactions into hemodynamic optimization of the individual. So if you look at the mean arterial pressure, two determinants are very important: the peripheral vascular resistance and the cardiac output. The cardiac output is determined by the stroke volume and the heart rate, whereas the peripheral vascular resistance is determined by the vascular tone and structure. Stroke volume is a reflection or a result of preload, that means how much you are filling into the heart at the end of diastole, how well the pump is contracting, what is the horsepower, that is myocardial contractility, and what is the caliber of the pipes and how much resistance is this heart or the blood vessel facing when it tries to pump off, whether it's the right ventricle or the left ventricle. Both of them face a little bit of pressure upstream, that is called as the afterflow. So the mean arterial pressure, essentially being a factor of cardiac output and peripheral resistance, is an integral component of understanding cardiovascular physiology. So this is the interaction. So the mean arterial pressure is actually the apex of this cardiovascular physiology pyramid. So we have the water and sodium handling from the kidneys, which actually involves the blood volume and the venous compliance. And this venous compliance and the blood volume reflect the central venous pressure. Although we are not currently relying on this pressure, but it is there. It's a physiological entity. You can't say it is not there. That actually produces the preload. Whether it's a marker of preload is a matter of debate, but it is the cause of the preload on the right side of the heart. So that preload triggers the stroke volume, the cardiac output, and the mean arterial pressure. So there are multiple factors which involve the other issues, that is inotropy, the heart rate, and the systemic vascular resistance. In physiological state, like you, for example, today you are sitting here, listening to this, your heart rate is probably very stable. So it probably the cardiac output is good, but now after the lecture you go on to the beach and take a run on the beach, your heart rate is an integral representative of how high your cardiac output can go. But that cannot be extrapolated into a critically ill patient where heart rate is essentially already high. Any further, you don't increase the heart rate in the critical care setup to increase the cardiac output, because those patients are already tachycardic. So any more increase in the heart rate would probably increase the oxygen consumption and extraction ratios and cause more harm to the patient than good. So you focus on the stroke volume and try to optimize the stroke volume, because other than the heart rate, that is the determinant of cardiac output. So you play around with stroke volume and augmentation of the stroke volume more in a critically ill patient than increasing the heart rate. However, if the heart rate is lower in patients who have symptomatic bradycardia, you probably will manipulate the heart rate to bring it to an acceptable level to generate the cardiac output needed for the patient. So the cardiac output, this is essentially the same thing, stroke volume and the heart rate. The stroke volume decides the diastolic filling volume and the systolic ejection volume, and both of them will ultimately result in the circulating volume based on the ventricular compliance and relaxation. So if you look at the relationship between the systemic vascular resistance and the cardiac output, it's not so. As the stroke volume resistance, as the cardiac output, as the systemic vascular resistance rises, to a particular extent, the cardiac output tries to compensate, but then it comes to a phase. So you can look at that relationship in health. When the systemic vascular resistance is normal, there is a linear relationship between the systemic vascular resistance, the cardiac output, and the mean arterial pressure. But when the systemic vascular resistance is reduced, as happens in vasodilated state, like prototype being septic shock, you will find that after a period of time, when the mean arterial pressure actually rises, the cardiac output is high, but the mean arterial pressure is not matching the levels at which it would have done if the systemic vascular resistance was normal. So the systemic vascular resistance is therefore a determinant of the cardiac output based on the relationship between the contractility and the load which the heart is. But physiological systems have inbuilt backups, like you have a failure like this, you should have a backup system which will take over with very little transition time, and that is auto-regulation. So fluctuations in mean arterial pressure, fluctuations in systemic vascular resistance are taken care of by the auto-regulation, which tends to keep the perfusion pressure acceptable between 55 and 110 millimeters of mercury. But when there is a dilatation of the vascular system or an excessive constriction of the system, this auto-regulatory system usually decompensates and your perfusion pressures actually fall. This is highlighted in intracranial events. You know that auto-regulation is very well understood in cerebral circulation, but the same auto-regulatory phenomena happen in the coronary circulation, they happen in the splanchnic circulation, they happen in renal circulation. And that is the physiological rationale for acute kidney injury or acute kidney disease that happens in hypotensive patients. Who become polyuric. They are not in shock. The blood pressure drops, your urine output falls. But that is because the auto-regulatory mechanisms are probably already compromised because the change in the vascular architecture, maybe because of diabetes and age, and therefore the perfusion pressure becomes lower. So end of the day, if you believe in a mean arterial pressure, you have to understand that it acts through perfusion pressure. And it is not only the brain which relies on perfusion pressure, the perfusion pressure is an all-pervasive entity. You look at the brain, the heart, the kidneys and the intestine, every single organ which is vital to the physiological homeostasis has a perfusion pressure. And as I mentioned, the mean arterial pressure is a big player in the genesis of this perfusion pressure. So defending these perfusion pressures becomes the fundamental basis for which you give volume, you give vasopressors, or you try to increase the contractility of the heart by using an electrode. Your attempt is either to increase the mean arterial pressure or to manipulate the other parameters which are determining the perfusion pressure. So you can use ICP, you can use the intrathoracic or transpulmonary pressure, you can use the intra-abdominal pressure to understand how much blood flow your organs are actually getting. So having a mean arterial pressure of 80 or 70 is not enough for you to say, I have resuscitated my patient. Now if my intra-abdominal pressure is 25, for example, a mean arterial pressure of 70 is not going to be enough for that patient because my abdominal perfusion pressure is less than 55 millimeters of mercury. So my gut is not going to be perfused, my liver is not going to be perfused. So I end up getting multi-organ dysfunction. Now all this, as I said, is dependent upon how much blood flow is coming back into the heart at end diastole. Right? Unless your bank balance gets filled up by the end of the month or beginning of the month next month coming tomorrow, you don't know how much of your EMIs you can service on the 15th or the 5th or the 10th of next month. So that is venous return. That is why it's important, right? It is the flow of blood from the systemic venous network towards the right heart, and in steady state, that means when there is no peripheral cooling, there is no vasodilatation, there is no leaky capillaries, the venous return equals the cardiac output. So the right heart actually has to face the entire cardiac output as the left heart is generated. So it has to have that capacity, therefore it works against a low resistance circuit upstream in the pulmonary circulation. Because it has to match the cardiac output, the venous system is a capacitive system having high compliance. And I will talk about it in a little bit detail when I talk about mean systemic filling pressure. So the determinants of venous return will be the right atrial pressure. So if the right atrium is already under pressure because of a failing chamber upstream or a compromised circulation in the pulmonary circulation, the venous pressure, because it's a low pressure circuit, cannot drain into the right heart. So the pressures on the right side of the heart, whether it is intrinsic because of a failing right heart or extrinsic because inappropriate use of positive pressure ventilation, will result in an impediment or interruption of the flow that is coming back into the right heart. So that is the resistance to venous return. Ultimately, it is the main systemic filling pressure which is the player which determines whether somebody has a capacity to increase this venous return a little bit more than what it would be with a closed circuit with a steady state. That brings us to the concept of unstressed volume. So the circuit, that is the right heart, the pulmonary circulation, the left heart, the peripheral blood vessels, that loop is a stressed volume. That's a closed loop. But there is a component that is outside this, which is waiting to step in when this closed loop is compensated. When this closed loop is unable to meet the cardiac output requirements of the individual, that is the unstressed volume. The volume of fluid in the circulatory system which does not produce any stress on the walls is the unstressed volume. This is a physiological state in the state of health. That is usually 0 millimeters of mercury because it is not acting on any blood vessel to distend a pressure upstream. And this unstressed volume constitutes 85% of the blood volume. It's not a small number. So if you look at that, the unstressed volume, so whatever is playing to produce the pressure is only 15% of the blood volume. So the amount of blood that is migrating from the arterial to venous system is about 4 ml per kilogram, approximately 300 ml. Now if you remember this number, 300 ml, this is the amount of fluid or volume that is supposed to be returned back to the circulation when you do a passive leg raising test in your individual. This is the physiological basis of understanding that the passive leg raising test is an effective method of using your own unstressed volume to see whether your vascular system responds to an augmentation of the circulating volume. So this is where you get 6% of the total circulatory volume is what you are actually getting as a figure. The venous system, the capacitance system, holds 70% of the total blood volume, that is about 3.5 liters. And the venous compliance, the compliance of the venous system is 40 times more than the arterial compliance. Therefore, the unstressed blood volume is 70% of the total blood volume. If you constrict the veins, it moves this unstressed blood volume to stress to bring it back into the stressed blood volume. So when you use a general vasopressor, like a norepinephrine for example, while it is actually causing arteriolar constriction and increasing your mean arterial pressure by acting at the afterload, its main action, which we don't realize, is actually to constrict the venous system and pump this unstressed volume into the circulatory system. Now that is the rationale probably why we are now considering early vasopressor therapy when patients are likely to require large volume fluid resuscitation. Not because we are going to increase the arterial side of the pressure. We are utilizing the effect of norepinephrine on the unstressed volume, and actually we are using it as a fluid challenge by compressing the venous system and returning a portion of this venous capacitance blood volume, which is 70%, back into the circulation, probably about 300 to 500. But the mean systemic filling pressure behaves in a very peculiar way during when there is a normal circulation and when there is profound shock and circulatory arrest. So the mean cardiac filling pressure, if you take out the venous capacitance vessels and only look at the closed loop, that is called mean circulatory filling pressure. When the patient is in circulatory arrest and when the patient is in profound shock, the mean circulatory filling pressure actually remains a little high. It remains a little high because the capacitance before the heart stopped was actually trying to pump in more unstressed volume back into the circulation as a compensatory phenomenon. So, in practice, if you want to experimentally find out what is the mean systemic filling pressure, the easiest way, if you have a central line in a patient who had a cardiac arrest and had an asystole, at the point of asystole, just connect the central line to the venous pressure and you'll find a trace. That is the mean systemic filling pressure. That was the pressure which the body was trying to generate to bring back the unstressed volume into circulation. So this is the relationship between the stressed volume and the unstressed volume and the mean systemic filling pressure. It is therefore an integral player in the whole path. You look at the compartment. This is the venous, the systemic circulation and the venous capacitance. And this is the amount of fluid that is retained by the mean systemic filling pressure, and the gradient between the mean systemic filling pressure and the right atrial pressure gradient is the one which actually facilitates the return of your cardiac output back into the right heart after it has left the left heart in the previous systolic cycle. So if you look at the normal circulation, this is the main system, this is the normal circulation. You can see that the main systemic filling pressure actually is about 6 to 8 millimeters of mercury, or maybe a little less than that at the central vein level. So same picture I showed, when you have profound shock, it actually remains a little higher. This is because of the compensatory mechanisms which the body has already started to initiate. When you look at the mean circulatory filling pressure, I may overshoot by 3 or 4 minutes because it's a huge topic. I request you to give me 3 to 4 minutes more. The mean circulatory filling pressure is the pressure that would be measured at all points of the circulatory system if the heart was stopped suddenly, and this is what I mentioned. It is the pressure exerted by the wall of the circulation on its fluid content, and it is a measure of the elastic recoil potential stored in those walls. So the mean circulatory filling pressure is a component of the mean systemic filling pressure. then you need to understand the equation between the left ventricular end diastolic pressure, that is the filling of the left side of the heart versus the stroke volume, and it has a definite point where it decompensates. And this is, not a fixed curve. It is a family again of curves where the left, depending upon the left ventricular compliance and its contractility, you can have different positions and where it can decompensate. So in health, if it decompensates here, in a failing heart or in a weakened heart, it fails much earlier at a much lower end diastolic pressure. So you keep filling up that heart with fluid, you are going to end up with the fluid going into the wrong places, which probably is the lung. So this is the much celebrated Franz-Starling curve, where all our physiological principles are set. And our patients in the intensive care unit are always here. They are not here. These are your hypovolemic patients who come with gastroenteritis or one of those normal fluid loss. This is the cardiac failure patients who will not respond to any kind of fluid therapy. But your septic patient, your trauma patient, your obstetric hemorrhage patients are here. And it's very easy for us to decompensate them by tipping them over if you do not understand the ventricular preload and whether that is actually resulting in a stroke volume related augmentation of the preload. So interpreting the Franz-Starling curve, understanding at which point of the Franz-Starling curve your patient is currently operating is an integral part of all the invasive hemodynamic monitoring tools which we have at this point of time. You may not have high-end gadgets, but use of an ultrasound can actually tell you in a controlled ventilated patient whether your IVC, increase in your IVC diameter versus the change in your lung profile, whether it is changing from an A prime profile to a B prime profile, will tell you whether augmentation of the volume is actually resulting in an increase in cardiac output or is resulting in the extravascular lung water. So that will tell you when to stop. Your patient may still show a positive test for fluid responsiveness, but if he is operating at the junction of the Franz-Starling curve, you are not justified in giving more fluids to that patient. So that brings us to the last component where we are all talking about the heart, right? But there is another player nearby, that's the lung, and they are interlinked. Because the volume that is coming into the lung, left heart, has to pass through the lungs, has to pass through the pulmonary circulation. When Rahul is sitting here, I have heard so many talks given by him on right ventricular function and heart-lung interactions. So you should correct me if I miss something, Rahul. But if you take the venous return, it comes into the right heart. And unless the left heart is compliant and is willing to accommodate the volume increase, this is a very poorly endowed ventricle in terms of muscle mass, in terms of blood supply, and it is not used to heavy work, right? It's a lazy ventricle. Not lazy, but it's a very relaxed ventricle. It works against less resistance. It's not very, craving for oxygen because it's a thin-walled ventricle. So any changes in the size of this left ventricle, which compromise the cavity size of the right ventricle, will compromise its filling. And when the size is compromised and it doesn't fill well, it doesn't empty well. When it doesn't empty well, the left ventricle doesn't get its inflow. Therefore, the consequent cardiac output will be the next cycle will be low. So the pulmonary vasculature is another impediment to the outflow from the right ventricle because it's a relaxed ventricle. But if there is an obstruction because of hypoxemic vasoconstriction, because of a foreign body, because of a thrombus, or because of compression from outside because of intrathoracic pressure, inappropriately applied positive pressure ventilation, and pneumothorax, for example, fluid collection, for example, the outflow from the right ventricle is impeded, which is, result of changes in the lung volume and intrathoracic pressure, which therefore has a direct effect on the stroke volume that is coming out of the subsequent cardiac cycle. So this important correlation between the inflow into the venous side of the heart versus the left-sided outflow, how it interferes when you apply varying levels of intrathoracic pressure by changing the tidal volume is reflected in several tests which we do. The passive leg raising test is supposed to increase your cardiac output by more than 10%. The mini fluid challenge, remember the 300 ml we spoke about? Something similar to that, 200 ml of challenge is expected to increase the cardiac output by more than 5%, which is positive trend. So we use this by looking at the Frank-Starling curve and whether the patient is actually at this part of the curve or at this part of the curve. But most importantly, the changes in intrathoracic pressure and their influence on the cardiac output, that means the filling of the right heart, the emptying of the right heart, and therefore the filling of the left heart and subsequent cardiac output are measured by several tests which we use in critical care practice. And those are the pulse pressure variation, the vena cava collapsibility, the end expiratory occlusion test, the tidal volume challenge test, and the samavedam. All these are reflections or adaptations of heart-lung interactions and see whether a change in the volume that is coming to the right heart can actually translate into a change in the cardiac output. The fact to remember is this produces a lot of caveats to the application of these parameters into routine practice, because the tidal volume on a breath-to-breath has to be constant. The patient should not be generating a negative pressure on his own, that means spontaneous breathing will interfere with his measurement. Apart from that, the diastolic filling of the left heart should be constant. So if there is an arrhythmia where there is a variable filling of the diastolic filling of the left heart, then the output will be variable. It is not a reflection of the changes in intrathoracic pressure. So these three caveats have come from the fact that there has to be a constancy in the way the pressure that is being given to the right heart or around the right heart is constant throughout your measurement. The diastolic filling is not compensated, not complicated by non-intrathoracic pressure related issues, and there is no negative pressure that is generated by the patient. So these caveats will apply to all the non-sonographic indices which we are using to apply heart-lung interactions to assess the hemodynamic status of the individual. So we have understood that there is a pump. The pump produces pressure. That is there is a compliance upstream and there is pressure. So that is all related to the delivery of the tissues. How are the tissues going to extract this? How do you measure? Right? I am giving 10 liters of cardiac output to the patient. Is my periphery happy with that? This is the ultimate. This is the last aspect of this equation. So that is the central or the superior vena cava oxygenation. Although we don't use it very regularly in our practice anymore, the reverse actually highlighted this, but it's fallen out of favor. So wherever there is a mismatch between the oxygen consumption and the delivery, you get mismatch in SCVO2. We don't target, now we don't look at low SCVO2s and try to augment it with fluids and other drugs at this point of time. But combination of the SCVO2 with the arteriovenous carbon dioxide delta is an integral part whether your oxygen delivery versus your consumption are effective. If your patient has an SCVO2 crossing 80%, that means your resuscitation is not going in the right direction. It doesn't mean you do a particular intervention, but maybe you need to look at your acidosis as an important component of interfering with the electron transport chain at the periphery. It is a marker that the cardiac output, the intravascular volume, the mean arterial pressure, the cerebral, the systemic perfusion pressure which you are generating is not achieving the target for which you have made the therapeutic changes for that particular patient. You need to rethink your diagnosis. You need to rethink your strategy for optimizing the pressures of the patient, whether it's on the venous side or on the arterial side. So in summary, understanding of physiology is key to understanding hemodynamics. It is understanding critical care, right? As we understand critical care more and more, our understanding of physiology has actually improved. And unless you understand the physiological principle of doing an intervention or applying a test, you will not be able to interpret in a rational way to do benefit for the patient. The pressure-volume relationships everywhere in the body are non-linear. So you need to know when to back off on the volume so that the pressure does not do damage to the organ to which you are applying the volume. The main systemic filling pressure is a less understood but a key player in the entire physiology of hemodynamics at the bedside. But end of the day, integration of multiple variables in understanding the cardiovascular physiology is the key if you want to make a quick turnaround for a patient who is compromised from his circulation perspective. Thank you very much and see you all in Hyderabad in May.
Thank you, sir. Wonderful talk on applied physiology, cardiovascular physiology in KL patient. And I hope anyone